Okay, we're going to call the Committee of Health and Human Service Policy back to order. Our next bill up will be House File 921, Representative Liebling. Chair Liebling, would you like to move your bill, please?
Thank you, Madam Chair. Well, I'm not a freshman and this is not my first bill, but I'm still sending treats around. Just because we're all hungry and cranky and tired at the end of a long day, at the end of a long week. I know, Representative Pearson is never cranky. He is never cranky. Okay. House File 921, members, is a bill that would, we heard earlier a bill from Representative Cantrell about carving out the prescription program from our public programs. And this is a bill about carving out our dental program in our public program. So many members in this legislature have had their constituents complain that, and I'm talking here about constituents who are on our public programs, that they cannot get dental service. It's covered under their plan, but they have great difficulty actually getting service. And this has been a problem for as long as I've been in this legislature. So there are, on the other side of it, we've had complaints from dentists for many years about the way these programs are administered. As you know, under each of the HMOs that contract with the state to provide this, they hire a dental administrator. And so every HMO that does our programs is doing it a little bit differently. We as legislators never know how much they pay. And this is something we've called over the years, we've kind of called this the black box. And I've been engaged in numerous conversations around these tables over the years about the fact that we as legislators are appropriating money for these services. Our constituents call us up and say, I can't get a service. A dentist calls us up and says, they're not paying me enough to provide the service. And yet we don't even know how much a dentist is being paid underneath these HMOs under our so-called PMAP program, prepaid medical assistance program. So this has become an enormous problem. We try all kinds of approaches. We've had numerous debates about Rule 101 and how we can change it, and raising the reimbursements to dentists, and how we're going to do this. But one of the real challenges we face is that we've outsourced our program to the HMOs to administer, and given the complaints we've had over the years from both dentists and from our patients, this has been a real challenge. And I would venture to say they have not done a good job for whatever reason. Now, I don't want to put them all in the same basket. There have been some that have done better than others. I think we have had pretty good effects with the county-based purchasing. We've heard some better news from them about the ability to provide dental care to our patients. But this is a proposal that actually this year, I've had this idea for a while. This is a bill that is carried by Julie Rosen over in the Senate. So this is a bipartisan effort. And Representative Zerwas, as you'll note, is the second author on the bill. So we've got Liebling, Zerwas, Cantrell, Fisher, Hamilton, and others. I don't know how many others are on it now. But I think this is an idea whose time has come. The governor's budget, thank you. The governor's budget has in it something similar to this, but this is the bill that actually originally came from Senator Rosen. So this is the companion to Senator Rosen's bill. It may not be, it certainly is lacking in details compared to the governor's proposal, but I would like to move this along just in order to have it in the mix. I think we also, of course, have the governor's proposal, and I think we're going to end up with something probably closer and more detailed in line with that one. But so I do have an amendment to the bill, Madam Chair, and I would like to move the A1 amendment to get the bill in the order in which I would like to be moving it here.
Chair Liebling, I don't believe you moved the bill yet.
Oh, I'm sorry.
Move the bill and then.
All right, well, I would like to move House File 921 to be re-referred to Ways and Means, and I would like to move the A1 amendment to get the bill in the order in which I'd like to be discussing it.
All right. So Chair Liebling moves the bill, but she also moves the A1 author's amendment. All in favor say aye.
Aye.
All opposed? The motion prevails and the amendment is adopted. Chair Liebling.
All right, thank you, Madam Chair. So I've pretty much discussed it. What the amendment did was change it to a single dental administrator from, it used to say up to two, and then to take out a line that I gather was causing some heartburn, and that was the 2.2 to 2.3 that specified what the payments would be. And in fact, members, what the payments would be, I think, is still a work in progress, because clearly we have two problems in our dental care, provision of dental care in the state. Two buckets of problems, I would say. One is we have payment issues, and it may be that we're not paying enough in certain places and for certain categories of dental providers. But we also have resource problems. We may not have the resources we need in all sections of the state. So this is not in and of itself panacea, but I think it would make a big step forward, because if we had a single program, we would eliminate a big problem for a lot of our dentists, that they have to deal with multiple insurance companies, all for people who are on the same basic program, which is something they really dislike if they take Medicaid and MinnesotaCare clients. And we would have more control over what those rates are. So with that, I would take questions, and okay.
And why don't we go to testifiers? Dominique Osito? Thank you, and welcome to the committee. Can you please introduce yourself for the record, who you're with, and proceed with your testimony?
Thank you, Madam Chair. Members of the committee, my name is Dominic Spizzetto. I am a contract lobbyist for the Minnesota Dental Association, and I'm here on behalf of the MDA to encourage you to support this legislation. First off, I'd like to commend Representative Liebling, as well as the governor, and particularly the Department of Human Services, who's been working rather diligently on this this proposal for almost almost 3 years. And in the last year, the department has gone out and visited a variety of dental providers throughout the state, particularly in greater Minnesota, where we think we have our greater access problem, and really worked on what the issues are. And I think Representative Liebling's proposal deals with the single administration, and eventually will deal with the reimbursement issue as well. And we think it's time to make a change. We've worked on this with Representative Liebling for now, I believe, almost 6 years. And we're finally getting to the point where we're at a crossroads. Because if we don't do something different, we're condemning ourselves to a system that's broken and, frankly, getting worse. We're getting some very seriously bad grades from CMS related to our children's program. In fact, access to children's services has gone down under our current system. Part of the problem is that we're blending dental care in with medical care under a managed care system. And granted, I think it would be a good idea at one point in time to make medical and oral health issues integrated. And in some cases they are, but through the majority of the dental system, they are not. And in fact, we have a separate dental delivery system in this state, and that's particularly one of the reasons why you have dental insurance instead of medical insurance that includes dental. And part of it is the system, its tradition, part of it is the way it works, and part of it is the fact that we will eventually coordinate this, I think, in the future, but we are far off from doing that now, and I don't think we can continue to keep a system based on a model that is not yet ripe. The reimbursement issue, I think, is paramount, and as Representative Liebling said, this does not directly address that question, but we hope it will when we get through the finance committees. And I just want to mention a couple things about reimbursement. One is that the reimbursement system for dental services under public programs is based on the last century. The fees are based on schedules that were created in 1989. So folks, we're 30 years behind on what we're looking at to begin a base rate to pay dentists for public care programs. And we've made attempts over the years to make it work better. We've added what we call add-ons. We've done several attempts with critical access provider payments. We've done raising pediatric codes. Nonprofit clinics have a 20% add-on under statute. And there are rural add-ons for certain providers depending on where their practice is. But that has not worked. And what it's actually done is created a very complicated and confusing system of reimbursement where the dentist can't really tell you what they're going to be getting paid, and you as the state appropriators don't know that as well. We don't have a fee schedule that is across the board applicable to any dental practice. They could have 6, 7 different kinds of schedules based on who they're contracting with to provide the services. Let's view it from a patient standpoint. You're a patient in one area of the state, and you go to a dentist, and that dentist is being paid 85% of their submitted bills. In another part of the state, you go to see the dentist, and they're paid 28% of their submitted bills. The services are the same. Hopefully, it's all quality care. But why is there such a difference? It's because of the system that we created. And the only way, I think, to address that is to basically start over, go to a single administrator, carve dentistry out of the system, and establish a uniform fee schedule. Now, if you choose to add add-ons to that, you can. It'd be your choice, and I would encourage you to look at that if you wish. But at least we're starting with a base that we know what it is, and that we could determine the expenditures, we can determine the reimbursement, and hopefully we could look at periodic opportunity to increase the reimbursement as dental expenses go forward.
Well, thank you for your testimony. We have our next testifier will be Matthew from the Minnesota Oral Health Alliance. Welcome to the committee. Please introduce yourself for the record and who you're with, and proceed with your testimony.
Thank you, Madam Chair and members. My name is Matthew Bergeron, and I'm an attorney with the law firm of Larkin Hoffman. I'm before you today representing the Minnesota Oral Health Alliance, a coalition of critical access providers who serve over 250,000 low-income and uninsured Minnesotans. I'm here to discuss how elements of House File 921 impact safety net providers and a couple of the potential unintended consequences the proposal might have absent additional considerations. However, first, I would like to begin by thanking Representative Liebling for the A1 Authors Amendment. While House File 921, as introduced, preserved the critical access, rural access, and children's rate enhancements I discussed when this committee heard the governor's proposal in House File 3 last week, the language on page 2, lines 2 and 3 that was just deleted would have still resulted in decreased reimbursement to safety net providers. Under the current PMAP system, most, if not all, managed care and county-based purchasing organizations pay higher rates than those paid by DHS as part of the traditional MA fee-for-service rate schedule. This is a result of a variety of market forces as well as the state's network adequacy requirements that lead PMAP organizations to offer higher rates in order to get providers into their MA network. Without a broader discussion of what the rate reform would be included as part of this proposal, safety net providers would stand to lose an estimate of at least about 8% on the base reimbursement, and that's prior to the rate add-ons. However, as Representative Liebling just noted, that language was struck from the bill as part of recognizing that broader conversation needs to happen, and we appreciate that. As I have said before, the Minnesota Oral Health Alliance believes that any proposal that reforms the manner in which MA dental services are reimbursed should seek to hold safety net providers like those in the Oral Health Alliance harmless. The current PMAP system involves more than simply claims payment, whether it's with respect to increased base rates or the medical dental care coordination services provided by managed care and county-based purchasing organizations. The Oral Health Alliance believes that a reform on this magnitude needs to be undertaken deliberately with considerable input from stakeholders if we need to avoid a myriad of unintended consequences from losing some of those benefits currently in the system. The Oral Health Alliance looks forward to working with Representative Liebling and committee members as this proposal advances through the legislative process. And thank you again for the opportunity to speak with you. I'm more than happy to answer any questions.
Thank you so much for your testimony. Our last testifier is David Gesco from the Health Partners Dental Group. Welcome to the committee. Please introduce yourself for the record, who you're with, and proceed with your testimony.
Thank you, Chair Moran. Committee members, my name is Dr. David Gesco, and I'm the Senior Vice President and Dental Director for Health Partners, and I am also a practicing dentist in Minnesota. Additionally, I'm a current member of the Minnesota Board of Dentistry and have served there since 2012, where I have held all board offices, including president. I am also a long-standing member of the Minnesota Dental Association. I'm also testifying on behalf of the Minnesota Council of Health Plans. I'd like to acknowledge Representative Liebling, and I am here also, and I share her concern for access in Minnesota. However, this bill, as it is written, in my opinion, will do nothing to solve that problem. It's fair to say that I've spent my entire career working towards the goal of improving the practice of dentistry, and I truly believe that the integrated practice at Health Partners, combining both medical and dental care, and our role both as a payer and a provider of care, makes this the best place I could possibly deliver quality dental care to patients. I am also a nationwide speaker on a broad spectrum of topics. However, far and above, what I am asked to speak about is that of integrating care. Clearly, all the momentum in the country is towards greater integration. This momentum is breaking down silos where patients get handed off clumsily between distinct providers and groups that have no connection, and towards seamless care where systems are highly connected and integrated. A great example of that is at Health Partners, we have an integrated record system that spans all providers at Health Partners, from clinics to hospitals, dental to medical to pharmacy, and truly is an example of how integrated care can improve care. I have always seen Minnesota as a highly progressive and innovative state. After all, we were the first state in the nation to authorize dental therapy for all citizens. That move, now almost a decade ago, has greatly improved access to care and decreased cost across Minnesota. This bill, running counter to this concept of integration, defies this momentum and pushes us back in time. With all due respect, I see this akin to eliminating such advances as public transit and returning to a paper system and away from the simplicity of online services. Perhaps we should promote the return to the 8-track tape. In my role, I am privileged to receive comments from our patients and members. I'd like to comment on the frequent and regular comments received relating to how in dental we discovered what became a significant overall health problem. Many times this comes as a result of taking blood pressure readings on all new and recall patients. This simple practice defines low-hanging fruit and the comprehensive treatment of patients leading to optimal overall health. In our highly integrated system, we are able to quickly refer a patient for assessment of a high blood pressure reading, leading to diagnosis and treatment. Millions of dental patients across the country do not seek regular medical care, and the dental office is a prime site to assess overall health and make the simple and appropriate referrals. Our dental group is really unique in this state. We served almost 30,000 patients on public programs last year just in-house, in addition to those that are members of our HMO plan that see our contracted network. Health Partners provides integrated medical and dental care to all of our patients regardless of insurance. All of medicine, including dentistry, should be moving toward more integration of care, not building new silos. A single administrator moves us to silos, which is not in the best interest of patients. The OLA report in 2013 also noted that less than a quarter of dentists cited administrative burden as the reason they do not seek program enrollees. 90% cited the low reimbursement rates for Medicaid. It would be important to consider the following points if this is the direction that the state chooses to take. Patients will lose any connection to medical care unless the administrator chosen can coordinate care with the health plan through which the enrollee receives the rest of their care. For me, this is the most fundamental reason not to do this. It's bad for the patient under my care because their mouth is connected to the rest of their body. It's unlikely that a DHS-run single administrator would have the ability to measure health outcomes in the same way that an integrated system can, which is in the best interest, again, of the patient. This bill also does not have an important component of tying payment to outcomes and making that a condition of a bid process. A single administrator, as noted by DHS in a previous report, as well as the 2013 OLA report, will likely not pay dentists as much to treat state public programs employees as they currently receive through the managed care organization's capitated rates, meaning that public program patients will have an even more difficult time assessing needed dental care. According to their own data, the payer with the worst access problems and lowest payments itself is DHS. Contracting with a new entity to manage all dental care, currently they allow managed care organizations to do it as a part of the capitated rate, will be a significant change in DHS and would require substantial new resources from the state. We do support streamlining of administration for dental payers, a better approach. States that have seen successes in increasing access rates have also partnered with dentists to help navigate the Medicaid process.
Can we wrap it up?
Yep.
Thank you.
We also think that it would have more impact to target funding to the dentists who are willing to serve those patients. In conclusion, we believe that all patients, not just those served by public programs, value our ability to provide robust, convenient, flexible, patient-centered, and integrated access. We hope that any action taken by the state and by DHS on this issue would align with the triple aim and be patient-centered, improve care, and improve access. Unfortunately, this bill doesn't do any of those things. I'd be happy to answer any of your questions.
Thank you for testifying. I'm going to open it up to Representative Liebling to maybe respond.
I'm sorry, Madam Chair, I can't hear you.
I'm sorry, Chair Liebling, would you like to respond to or speak next?
Well, Madam Chair, I just, people are buying old LPs, and sometimes the LPs are better than the newfangled stuff. So I don't know. I just find that analogy really, really strange, but that's all I'll say to that, Madam Chair.
Okay. Is there anyone else who would like to testify on House File 921? Any discussion from members? Representative Albright.
Thank you, Madam Chair. Representative Liebling,
You don't need to stay here unless they call you.
when, in your opening comments, you mentioned that you don't have the data, I'm just trying to clarify, but dentists already are providing that data, or MCOs are providing the data to DHS on the reimbursement rates and their activities. Isn't that correct?
Madam Chair, Representative Albright, I don't think I said we don't have the data. I said, and I know DHS obviously monitors, but, if you go and ask Health Partners or any of the MCOs, what are you paying a dentist, or what are you paying for, delivery of a baby or any service, they will tell us that's proprietary. We don't have to tell you, we won't tell you. That's been our challenge as legislators for years. When we go and we've raised rates, people come in and say, we need a rate increase on this and a rate increase on that. And whether the MCOs are passing that along or how much of that goes to the practitioner, we don't have control of that, and we don't even know what it is. There's been a constant struggle in this legislature for we as legislators to get access to that information so that we even know. And I believe DHS does have access to it, but they're not allowed to tell us, which is really strange because, this is, the MCOs will tell you, this is proprietary. It's a trade secret. That's why they don't have to give it to us, won't give it to us. And we have struggled with that over the years, bipartisanly. I mean, members who've been in these committees, as I know you have, over the years have been very, very frustrated with our inability to find out what is actually being paid.
Representative Albright.
Thank you, Madam Chair. I guess I'm going to ask or recall Dr. Gesko.
Mr. Gesko? Dr. Gesko? Okay, Representative Albright.
Thank you, Madam Chair. Dr. Gesko, is that information, the payment rates, the reimbursement rates, is that proprietary or is that known to people? And how is that reported? Is it reported? Who has availability to it? Because there certainly seems to be some cloud of mystery around what the reimbursement rates are or what you charge.
Dr. Gesko.
Madam Chair, members, I would enjoy to follow up with you and any of the members offline and completely unpack and look into that. I know it's always thrown out there that money goes in and who knows what goes out. We spend a significant amount of money towards this mission and always end up losing money. And so I would welcome the opportunity, along with others on my team, to be able to sit down with you, Representative, and thoroughly go and look through this very, very carefully.
Madam Chair, Dr. Gesko, and to the extent that you could provide a Reader's Digest version for the members on this committee, I'm imploring you to, to the extent that it's not proprietary, I'm wondering what you can share with the committee in the brief amount of time that we have with us today. Because there seems to be, some question in terms of who has the data, who does it get reported to? Does DHS have this data? Is it reportable? The rates seem to be at question, and there's a suggestion, and I think it's believed true, that the nonprofits, MCOs pay a higher rate
That's correct.
than others. So, to me, I'm experiencing some dissonance here in terms of the proposal versus what already is in fact. If we adopted the proposal, wouldn't we in fact be taking a step back in the reimbursement rates to dentists?
Dr. Gesko, and it seems like we have somebody else might want to give us some information, but Dr. Gesko. Dr. Gesko, please.
Yep, Chair and members, I am experiencing the same dissonance, and as I said in my testimony, it would, in fact, in my opinion, be taking a step backwards. I began my testimony by agreeing that, along with Representative Liebling, that I have great concern for the access to dental care in Minnesota. However, this bill does not seem to address those things and would, in my opinion, make matters worse. I'm joined by Jeff Ogden, who is the Vice President of our dental plan, and he could perhaps answer some of the other nuances of your question, Representative.
Madam Chair, if you would be willing.
Dr. Gesko, could you allow your colleague to testify?
Yes.
Okay, thank you. Representative Albright.
Thank you, Madam Chair. To the testifier, I'm sorry, I didn't catch the name again.
Madam Chair, my name is Jeff Ogden. I'm the Vice President for Dental Plans at Health Partners.
Mr. Ogden, I'm trying to remember the paraphrasing I used for the question, and I hope you picked it up because I probably can't repeat it. But there just seems to be a dichotomy between what's in the proposal and what's already existent under the reimbursement rates. So I'm trying to understand if there is a movement towards a single administrator, how does that help the patient? If we are, in a sense, mandating rates that presumably, from what I can gather, are going to be substantially less, even with a bump up in a future committee. And we're talking about policy, I know, but what's the ramifications for this type of a change?
Madam Chair, if I could, there is nothing in this bill about what the rates would be, and I think there's a real assumption in that question, Representative Albright.
Madam Chair, if I could, and Representative Liebling, I think as we've heard before, policy begets, reimbursement rates, and so we're talking about moving to a single payer, and in the dissertation that you've given, as well as the preamble to the bill as well, you're going towards a reduction in the costs. And my presumption is I don't know how you can reduce costs without cutting reimbursement rates.
I'm going to let Alden respond.
Madam Chair, Representative Albright, I'll respond in a couple ways. First of all, I would also like to support the emphasis that Representative Liebling is putting on dentistry and access, because we firmly agree with that objective. Okay, with respect to the rate situation, the proprietary nature of the rates is in comparison to the rest of the market. We are very happy to disclose the rates that we pay in conjunction with the other payers in the market, as long as it doesn't put us at a competitive disadvantage. In addition, we provide to the Department of Human Services what we pay on a per-claim basis. So that rate information is completely available, as Representative Liebling indicated. It may be difficult to aggregate and report, and there may be some HIPAA requirements that you can't disclose individual claim information, but I do believe that it would be beneficial to report aggregate information on a per-claim basis to see what people are paying for specific claims across the broad population, which I think would accomplish the task that we would agree is beneficial to be more transparent in this respect. Okay, so we would be happy to participate. Our objective is the same. If we can increase access and transparency is supportive of that, we're supportive of that. I, however, also agree that divorcing the administrative aspects of the process through a single administrator is inextricably combined with what's being paid. We do not find that the administrative burden of participating with these programs is the primary impediment for practitioners to participate. In fact, practitioners will still have to participate with all of the same payers because they will have to deal with this on a commercial basis. And for instance, credentialing is the same. We don't credential differently for public programs than we do for commercial programs. So the reduction of administrative burden is, I think, fairly minimal in comparison to the rate issue. And a second issue of, is there a population that just doesn't want to deal with this population for other issues, for instance, no-shows, the complexity of dealing with this population. So it's divorcing this situation to just administrative aspects of a single administrator, we don't think is going to be the solution. So I hope I answered your question, probably broader than you wanted.
Chair Liebling.
Madam Chair, thank you. First of all, I'd like to say to Representative Albright, I didn't say that this would be cheaper. I don't think I said that. I don't know. It depends, on what we pay, obviously, is a big part of what the cost is of providing care. So I don't believe I said that. But I would like to ask Mr. Ogden a question, if I may, Madam Chair.
Yes.
Mr. Ogden, now understanding that Health Partners is both a payer and a provider of services. And I understand under the dental program that some of the providers who are paid by Health Partners are not actually Health Partners providers. For example, we just had an issue come up with one of our pages here in the House who's covered under MA by Health Partners, but actually was going to Park Dental for her dental care. And Park Dental is not part of Health Partners. So my question to Mr. Ogden is whether Health Partners pays those other providers the same rate that it pays its own providers within its own network.
Mr. Alden. Ogden.
Madam Chair, Representative Liebling, that's a great question, and thank you for asking that. The direct answer is no, we don't pay everyone the same. In fact, the plan has an obligation to a larger network, which includes Health Partners Dental Group. And in fact, we pay certain providers more that are not part of Health Partners Dental Group than we pay Health Partners Dental Group. We pay some less because we do have differential system of payments, which is based on supply, demand, and access.
So, Madam Chair, if I could follow up. So, Mr. Ogden, are you saying that on average, that you don't pay Health Partners providers more for a service than you pay other providers who are not in your network? Are you saying that there is no average differential that you're, because I have to say, members, I've been told numerous times that Health Partners is paying the providers, the dental providers in their own network at a much higher rate than they're paying the others that they are covering. And I want to know if that is true.
Dr. Ogden, or should we take it to Dr. Gessler?
I just wanted to comment to the committee, Chair, that first of all, Health Partners Dental Plan does not pay claims or rates to any of the Health Partners dentists. It's not any kind of smoke and mirrors. The money, the way that the money flows through the organization is that it just covers the expenses of the dental group. And so there is no rate differential because there is no differential of rates. We don't pay any more. And as Mr. Ogden stated, there are many providers, many providers in the state of Minnesota in our contracted network that if you did do a rate comparison, if you could, are paid more than Health Partners Dental Group.
Madam Chair, I wonder if there's someone from DHS who could come down to speak about this.
Is there anyone here from DHS? Hi, welcome to the committee. Please introduce yourself for the record, who you're with, and proceed.
Thank you, Madam Chair and committee members. My name is Giogo Hayes. I'm with the Minnesota Department of Human Services. There have been several questions, so I'll try to provide answer to get to some of them and be happy to answer more specific questions. To the question about whether or not we can disclose exact payment rates, we do receive, as was mentioned by Mr. Gesko, what's called an encounter claim for every member that sees that's in a managed care organization. Within that, we do have the paid rates, but we cannot disclose those individual paid rates for each individual service that's received, as was mentioned. However, we do analyses across the program in managed care. Sometimes we look at a specific service, we might look at a specific health plan, or we might look across the entire managed care program. And so we have done analysis on that. To Representative Albright's point, maybe I'll just mention, one of the things that's challenging in the comparison, and not to make more complex of this issue that's already extraordinarily complex, is the medical assistance program has a fee rate increase that was passed in 2017 of 23.8% for fee for service, but only for kids. Additionally, there's a critical access dental add-on of 37.5%. In MinnesotaCare, that critical access add-on is 20%. Additionally, there's a base rate increase of 54% for MinnesotaCare. Additionally, if you're a community clinic, you might get a 20% rate increase. Additionally, if you're a rural provider, you might get a 9.65% rate increase. So I doubt anybody followed that. And that just illuminates the point that every dental provider in the network, whether it's a fee-for-service or managed care, is getting a very different rate. And so what we hear from providers is, I'm a provider, and as was alluded, we did do visits with dentists throughout the state. We met with about 60 dentists. And one thing that we hear is it's confusing to them as to why, when they see a Medicaid recipient, they might get substantially less than the same provider that's doing a very similar service for another person on the Medicaid program.
So I'm going to make a statement here because this here reminds me so much about, when we're not going to get on this subject, you guys, but I'm going to mention CCAP, right? Because we have, right, we're not going there, but we have like a small daycare center who is a business, and they have parents who are on MFIP, so they're in the CCAP program. And so what I hear so often is that the rate of the reimbursement rate for a CCAP participant is so low that they really cannot afford to carry many of those CCAP parents because the rate is just so low that they can't afford it as a business. You know, and so I compare that to that because with dentists, if they are having an abundance of MA participants, the reimbursement rate is so low, is what I hear, that often enough they're making the decision whether or not they can really afford to continue to serve the most neediest kids who need the services because the rate is so low. But to make up for that low rate that they have to continue to receive from those participants, they make up by being able to, others who from the private sector or from other individual market, they can charge them a higher rate just to make up from the differences of the services they're trying to provide. So I just get that analogy because it just reminds me of what I'm hearing from dentists across the state of Minnesota is that the rate, reimbursement rate is just really low and they just can't afford it.
Well,
And so this bill here says that, what in my notes is that the bill requires that providers be reimbursed at a MA dental reimbursed rate currently specified in statute.
and Madam Chair, we removed that with the
So
amendment.
you remove that. So we're still trying to work on it.
Right.
But that's my comparison.
Madam
Yes.
Chair, and this is my final comment
Representative
on this.
Albright.
You know, I look at this bill, and I consider what is included in the bill after the amendment, and I think we can all agree that we would love to provide dental care for folks that are in most need of it, and I'd love to pay dentists what they're deserving of. But the way I interpret this bill doesn't do that. What this bill is intended is entirely different from what we are hearing from the conversations from the testifiers. If we looked at increasing dental reimbursement rates, if we looked at a centralized credentialing system, if we looked at a uniform prior authorization type of protocol, I think if we implemented those three measures, the need for this type of legislation would be substantially reduced. I respectfully, submit that to the author as well as to the chair. Thank you.
And Madam
Okay,
Chair, if
Chair
Mr.
Liebling.
Sposato could just make kind of a final comment as well.
Madam Chairman, members of the committee, what you heard today is an example of what the problem is. And keep in mind, health partners,
And just for the record, just make
I'm
sure we
sorry.
know who he's speaking with.
Dominic Sposato, Minnesota Dental Association. You've heard the complexity of what Health Partners does with their providers. Just realize that they're one of 7 of the PMAP and contractors that we deal with. So you could have a situation where a dentist is in 4 different networks and they don't know exactly what they're going to get paid at the same rate for the same service because they have a different contractor. And this is what we're trying to address. You as appropriators should know where the money's going. Dentists should be able to plan their participation based on a rate that they'll expect to get. And right now, we don't have that. And so we encourage you to move this forward. I know there's a lot of work that needs to be done, but I think it's a step in the right direction. Thank you.
All right, so there been no further discussion.
Well,
Representative? You're good.
Madam Chair, I'd like to renew my motion.
Okay.
That House
thank
File 921 be recommended to be referred to the Committee on Ways and Means.
Yeah. Yes. All in favor, say aye.
Aye.
All opposed? No. The motion prevails and House File 921, as amended, is recommended for re-referral to the Committee on Ways and Means. Our next bill up is House File 1378, Representative Liebling. Would you like to move your bill?
Thank you, Madam Chair. We're talking about House File 1378. I will move that House File 1378 be re-referred to the Committee on Ways and Means.
Okay, we have the bill before the committee. Chair Liebling, I understand you have 2 authors amendment, and that the first one is a corrective amendment?
Madam Chair, there are, let me see, I'm not sure I actually have both of those, both of the amendments. Members, there was an an issue with the engrossing process, and there were some amendments that were added, not by me, but by a GOP member in the Commerce Committee, who, and then one of the amendments was engrossed, thank you, and then, one of them was engrossed, and then another or two others did not make it into the engrossment. So what we're doing is correcting that. And I guess I would ask Ms. Clarkvist, who drafted this, whether the A8 needs to go first or whether it matters. I don't know. She's saying it doesn't matter. Okay. Well then, Madam Chair, I guess I would move the A8, and just note for members that this is basically putting into place a Republican amendment that was put on in Commerce that I accepted. So I would move the A8.
Okay, so Chair Liebling moves the A8 author's amendment. All in favor, say aye.
Aye.
All opposed? The motion prevails and the amendment is adopted. Chair Liebling, would you like to move the second amendment?
Thank you, Madam Chair. And then I'd like to move the A6-1, and this also really makes some, what I would say are technical corrections to this. Yeah, and just to put the bill in the form in which I would like to discuss it.
All right, Chair Liebling moves the A6-1 author's amendment. All in favor, say aye.
Aye.
Opposed? The motion prevails and the amendment is adopted. Chair Liebling, to your bill.
All right, thank you very much, Madam Chair. And this bill does essentially two things. It is, as you all will remember, in 2017, the Republican majority moved a couple of bills through the legislature. One was I can't remember the number of the bill, but one of the very early bills in 2017 was Governor Dayton's 20% discount program, 25%, I believe it was, on insurance. So this was a market stabilization. In that bill, there were other provisions which were less discussed. And one of them was a provision that took away the requirement that HMOs in Minnesota had to be nonprofit and opened it up to for-profits. So one of the things that this bill is doing, and it's being done in other bills as well, is just to replace the requirement that HMOs in our state have to be nonprofits. And I would like to focus, though, on the portion of the bill, Section 5, that is also puts back a section that was deleted, I believe, in the same bill. And this was deleted, members, without really any discussion. At the time, I don't think I was even aware of it. And there was just a repealer. And we repealed a section of law that had been in place in Minnesota for about 25 years or maybe longer. And that is under Section 5 of my bill. It was this language. All net earnings of the health maintenance organization shall be devoted to the nonprofit purposes of the health maintenance organization in providing comprehensive health care. No health maintenance organization shall provide for the payment, whether directly or indirectly, of any part of its net earnings to any person as a dividend or rebate. Provided, however, the health maintenance organizations may make payments to providers or other persons based upon the efficient provision of services or as incentives to provide quality care, etc. So with my amendment, I just made this section applicable once again only to nonprofit HMOs, because this section of law, if you think about HMOs in our state, our nonprofit HMOs, there are benefits to being a nonprofit, and our nonprofit HMOs are mission-driven, or they're supposed to be mission-driven organizations. So what this language that was in statute for so many years did was say that when the HMOs had net earnings, or if they were for-profits, what would be called profits, that those extra monies had to be used for the purpose of the organization. This language was removed from law, and the result of that has been, so far, $175 million in transfers by one of our MCOs, one of our managed care organizations, which I will not name right now, but has been named in another hearing that we had. And so this is really basic to our, I think, to the integrity of what we're doing here. We pay, under our PMAP program, many, many, many millions of dollars. And there's been a lot of debate over the years about whether the HMOs, managed care organizations, are actually bearing risk or whether they're not. And members have kind of come down on both sides because the way rates are done, the way our payments to them are done, we are required under federal law to have actuarially sound rates. And what this means is that they are in the position, if say they take on more than they thought and costs are very high and they lose money in a year, the next time the rates are set, they can come back and get higher rates so that they don't lose money. So the way all of this works is integral to this whole system is the idea that if they make extra money, that they spend it on health care for Minnesotans, that they use it for the purposes for which they are established as organizations. This language was taken out for a reason that was never discussed and never explained. And it has, as I said, resulted in some pretty bad consequences for the citizens and the taxpayers of Minnesota. And so what I am doing here is putting that back into law. There are other bills moving that are essentially doing the same thing, but I think this is a pretty important point. And and also I think Representative Cantrell was in the room. There he is. He's over here. Representative Cantrell is carrying a similar bill dealing with the nonprofit issue, and I've asked him to come, and if there are questions specifically to that, I think he would be very well prepared to speak to those. But I think that it is really critical to realize that when this change was made, it was made without the full discussion of what this was going to mean. It was done very quickly. The language requiring these organizations to be nonprofit was taken out in a number of places in statute. Without really a full vetting, I would argue, of what this was going to mean for Minnesota. So the amendments that I accepted in the Commerce Committee, you can read, and we just corrected them a little bit, but that is Section 8, essentially, to say that the sections about going back to only nonprofit status are not effective right away until there's these determinations that you can read in Section 8. So that is the bill, members.
Thank you. We're going to go to our first testifier, which is Ethan Vogel. Welcome to the committee. Please introduce yourself for the record and who you're with, and proceed with your testimony.
Thank you, Madam Chair and committee members. My name is Ethan Vogel, and I'm a legislative representative with AFSCME Council 5. I'd like to start by thanking you, Representative Liebling, for all your time and energy that you've dedicated to making healthcare more affordable this session and throughout your career here at the legislature. We appreciate your service. So AFSCME is a public and private sector labor union. We proudly represent over 43,000 workers in Minnesota. AFSCME members help make Minnesota happen. Among many other things, they work in our state's correctional institutions, they plow our roads, they work in our schools and our hospitals, and they help keep our kids safe from abuse and neglect. Our mission at AFSCME is to advocate for excellence in services for the public, dignity in the workplace, and opportunity and prosperity for all workers. So excellent services for the public. In the short term, of course, that means we must invest in these services. Excellent services over the long term, though, means we must, it requires responsible budgeting practices and policies which strengthen public trust in government. I'm here to express our support for House File 1378 because this bill will help strengthen public trust as we continue to invest public dollars in our public health programs. And let's face it, trust right now in our healthcare system, and more specifically, our health insurance industry, is at an all-time low. But you can help change that today by passing this policy and reversing course on the 2017 policy, which Minnesotans didn't ask for and do not want. What Minnesotans want and expect is that their public health investments be dedicated to promoting comprehensive health care, not used to benefit shareholders of for-profit companies. Madam Chair, committee members, thank you for the opportunity. Please support House File 1378.
And thank you for your testimony.
Thank you.
Sarah Greenfield? Welcome back to the committee. Please introduce yourself for the record and who you're with, and proceed with your testimony.
Thank you, Madam Chair, members of the committee. My name is Sarah Greenfield. I represent Take Action Minnesota. We have members, 55,000 members across the state in every county, and 22 organizational members working together for social, racial, and economic justice. We are supporting House File 1378 because in Minnesota we believe in fairness and the common good. That's why until 2017 we banned for-profit companies from selling health insurance, from operating as HMOs here. That change takes effect this year. Take Action Minnesota opposed the decision to allow for-profit HMOs to operate in Minnesota. We've frequently shared our concerns about the current use of nonprofit HMOs to operate in our public health care programs. And we do believe that the public's health is better served through expanding state health care. But allowing for-profit HMOs to operate in Minnesota is a leap in the wrong direction. While we're dissatisfied with the use of HMOs as a vehicle to provide health care, nonprofit plans do have a responsibility to benefit the public and are at least subject to oversight. United Health Group, on the other hand, is a Global 100 company. It's accountable by law to its shareholders, not patients. United Health Group has already obtained an HMO license in Minnesota this year. There's no need and no place for an actor like United Health Group in our state programs. United Health Group and its subsidiaries have been cited numerous times for fraud, just this month. 2 weeks ago, a judge ruled that, quote, a United Health Group subsidiary breached its fiduciary duty by adopting coverage guidelines that did not reflect general standards of care, end quote. The judge called the coverage guidelines fundamentally flawed and tainted by financial interests. On Wednesday, the Star Tribune reported that United Health Group was being investigated by the U.S. House for selling short-term junk policies that discriminate against, quote, discriminate against individuals with pre-existing conditions and put consumers at significant financial risk. Minnesota should be working toward a people-centered healthcare system like MinnesotaCare for all, not moving farther in the direction of profit-driven care. We urge you to support House File 1378.
Thank you for your testimony. And our last scheduled testifier is Ms. Catherine Schmidt. Welcome back to the committee. Introduce yourself for the record and who you're with, and proceed.
Thank you, Madam Chair and members of the committee. I'm like the bad penny who keeps showing up.
No, I thought I was.
I'm here on behalf of the Minnesota Council of Health Plans, and on behalf of the Council of Health Plans, I wish to offer our wholehearted support of House File 1378 as introduced. I am disappointed with the addition of the A61 amendment because those changes create the same problem we face with a bill we're going to hear in a little bit, House File 533, and various other bills that are moving through the legislature. The changes that Representative Liebling mentioned in the A6-1 amendment affect primarily sections 5 and 6. But let me go back to section 5 of the bill, and I engrossed it myself. She read the language from, I believe, Minnesota Statutes 2016, correct?
Yes.
Okay. And the language that was in the bill as introduced is identical to the language that was in the statutes in 2016. We support that. But what Representative Liebling has done with her amendment is to add the term nonprofit before nearly every instance the words or the term health maintenance organization appears. And the reason that's I'm pointing this out is because the effect of this is that it gives it creates a disadvantage in the market. All of these requirements will apply only to nonprofit HMOs. It doesn't apply to for-profit HMOs who are evidently already in the market here in Minnesota. So what we are establishing here is a very unlevel playing field, and I don't think that is the direction that the legislature necessarily wants to go in. I don't think the legislature wants to restrict and constrict nonprofit HMOs from being able to offer products to Minnesotans, to be based here, have 25,000 employees who pay taxes and support the community, while at the same time giving an undue advantage to for-profit HMOs who may be based in Connecticut or New Jersey. So I really urge caution on this language because, in our view, this creates a very unlevel playing field. Thank you.
Thank you.
And Madam Chair, I'd like to respond to that if I
Chair
may.
Liebling, yes.
So first of all, the whole bill says we're not going to have any for-profits anyway, so there wouldn't, under the bill, there would be no unlevel playing field. But even if that were not the case, if we just simply put back this language that we have been talking about, the reason this needs to apply to nonprofits is that nonprofits are different than for-profits. For-profits, by their very nature, use their profits any way they want to. That's the nature of being a for-profit. They give it to their shareholders. They send it out of state. They do whatever they want. Nonprofits have a special mission, and they get tax advantages for that mission. And that is why they should be treated differently. I don't know, maybe I could ask Ms. Commit, what advantages there are to being a nonprofit as opposed to a for-profit, but it is different. And I think that nonprofits do have a special advantage that they get from the people of Minnesota. Certainly, they don't pay taxes the way for-profits do, and they have special obligations.
Ms. Commit, can you respond?
Madam Chair and members of the committee, I would buy Representative Liebling's argument if it weren't for the fact that in her amendment on the back page of the bill, Section 8, it says, and now it will read, Sections 1 to 4 and 7 are effective upon the Commissioner of Commerce making a determination that these sections will not result in this disrupted market situation. And at the end it says, the Commissioner of Commerce shall inform the reviser of statutes when this determination is made. Well, that could be 5 years from now, 10 years from now. The point is, the language in sections 5 and 6 go into effect, because there is no effective date, go into effect on August 1st of 2019. So that immediately gives a disadvantage right there, and none of the rest of it goes into effect until a determination is made by the Commissioner of Commerce.
Thank you.
Right.
Representative Freiberg.
Thank you, Madam Chair. I guess I just want some clarification in response to what Ms. Commit just said. But so if you look to lines 1.8 and 1.9 of the bill, it defines the term health maintenance organization in Chapter 62D.02 as a nonprofit corporation organized under 317.8. The amendment that we adopted did add the word nonprofit in on page 3 in several locations. In every instance, however, it precedes the term health maintenance organization. Maybe my question is for Ms. Clarkvist here. It just seems like adding the word nonprofit in those instances makes no change, because health maintenance organization is now under the bill defined as a nonprofit corporation. Is that an accurate statement?
Madam Chair and Representative Freiberg, I think the issue is the effective date, because sections 1 to 4 and 7 are effective. The changes in those sections are effective contingent on determinations made by the Commissioner of Commerce. The change in the definition in section 1 does not go into effect until the Commissioner of Commerce makes that determination.
Oh, okay, I follow. Thank you.
Okay. Representative Fisher.
Thank you, Madam Chair, and this is Representative Liebling. I appreciate the work that you've been doing to bring these provisions back in. Of question I have is under Section 5, subsection 8A, net earnings. My questions come around is how are net earnings being defined? And where I'm asking the question from is I know that over the years, as we've talked about different things in the healthcare world, different accounting systems are used. I know I'm used to using generally accepted accounting principles. So what set of principles are being used in defining that? I'm kind of curious on that because I'm kind of concerned because under general accepted accounting principles, which most companies follow, you're pretty easy to see what's going on. I know that there have been some things when the legislative auditor has been trying to take a look into insurance and health maintenance, et cetera. They've had trouble finding it because they're allowed to use a different set of rules, accounting rules.
Chair Liebling?
Madam Chair, thank you for the question, Representative Fisher. You know, I think this language was in statute for about 25 years, and the Department of Health that, regulates HMOs had a definition. I think we could get the answer to your question. I don't have it, but we'd be going kind of way off the bill because this language is going back in that was, it's whatever the definition was is the definition that would still be there.
Representative Fisher.
Okay, and that's fine then. I was just curious, and I can follow up with you afterwards on that then. Thank you, Representative Liebling.
Representative Loeffler?
Thank you, Madam Chair, and if the answers aren't easily shared, I'm willing to learn later. But I was really struck by a hearing that we had about one of our nonprofit HMOs with for-profit subsidiaries, and my understanding is almost all of ours have for-profit subsidiaries or portions of their company. And do we have in statute a clear definition of when you get to qualify as a nonprofit? It has to be the majority of your business is nonprofit, but you can have some of it be for-profit. The majority has to be nonprofit. I'm just wondering if we're clear enough in our regulations to be able to implement this, because I support your intent, which is to have our health dollars really focused on health care and improving the health status of the populations of people served. But I've learned from that previous hearing that organizational structures have gotten much more complicated, and I just want to make sure that we can actually implement what you want when there are for-profit partnerships, subsidiaries. I don't even know the correct business legal terms to use.
Thank you, Madam Chair. I guess I would have someone come down from the Department of Health, and maybe they can, or it might even be Commerce. I think maybe Health is the, but again, we're a little bit, I know there are a lot of implications to this, but I mean, the bill is kind of bringing back what we had before.
Maybe I have the department respond first, and maybe you can
If this gets too complicated, we can set it aside, but I just want to make sure that we're able to get on record that it's our intent to have most of the work be nonprofit, if we can't have all of it.
Okay, please reintroduce yourself.
Yes, Madam Chair and members, my name is Diane Rydrick. I'm the Director of the Health Policy Division at the Minnesota Department of Health, and I'm wondering if Representative Loeffler could repeat the question.
My question is, as the bill is drafted, the intention is to have all health maintenance organizations be nonprofit. But we have nonprofit health maintenance organizations licensed in our state that we have learned have large for-profit subsidiaries, subdivisions. I'm not quite sure what the legal term is. And will this adequately address that the vast majority of their efforts has to be towards nonprofit purposes, or do we need to, as this moves along, think a little harder?
Please.
Yes. Madam Chair and Representative Loeffler, thank you for the question. You're right that the entities that we license as HMOs in Minnesota generally have very complex corporate structures. What we have seen in our experience, though, is that generally they are separate entities that might be within a larger envelope is the word I sometimes use because that works for me, of a holding company that might be nonprofit. So I think at a previous hearing, you heard from Medica that they provided an organizational chart that I think provided a good example of that. So you could see the nonprofit HMO that we license by the health department, and then a separate entity that is a for-profit insurance company. It is separately registered and separately licensed in Minnesota, but they are both, along with other entities, distinct entities, they are all part of a single nonprofit holding company. That type of a complicated structure is not unique to Medica. We don't necessarily fully understand or have transparency into the corporate structures and related entities of all of the HMOs we license, but we do know that many of them are part of larger structures like that. Many of them have both for-profit and nonprofit entities within a larger holding company, but they tend to be separately licensed as nonprofit or for-profit corporations within that holding company.
Thank you, Madam Chair. Just as this goes along, I'd love to work with you and others just to make sure that we have the appropriate walls so that nonprofit money serves nonprofit purposes and within a nonprofit organization, and that there isn't the ability to subvert the intent through clever structures.
Yeah.
Yes, could you please introduce yourself for the record and who you're with and proceed?
Thank you, Madam Chair and members. My name is Jay McLaren, and I'm the Vice President of Public Policy and Government Relations at Medica. And I appreciate the opportunity to answer some of the questions, particularly Representative Loeffler, that you had regarding the committee hearing that we had in Health and Human Services Finance on this topic. So I just want to emphasize and answer your question, the fact that our entire organization operates underneath a nonprofit holding company. And I know that there have been previous testifiers talking about funds going to for-profit companies and their shareholders. What was shared in the Health and Human Services Finance Committee that I'm pleased to share with you all is the sole shareholder of our for-profit company where those funds were transferred is our nonprofit holding company. There are no outside shareholders. So all the shares are held by the nonprofit company that operates under Chapter 317A of Minnesota statutes. So there are no outside shareholders. So to reemphasize the points that Ms. Commit were making regarding the playing field or the unlevel playing field that this bill now creates, all of the funds inside our organization stay under that nonprofit holding company, stay in our healthcare system to serve our members. In contrast, for-profit HMOs are allowed, even under the bill that's under consideration by the committee, to send money outside our healthcare system to shareholders. Thank you.
Madam Chair.
Chair Liebling.
And so, Madam Chair, I guess I would like to ask if they don't do this, if Medica uses all of its money for the nonprofit purposes of healthcare, whether they object or no one knows, no one's been able to tell me why this language was removed from statute. It just happened in the dead of night, no discussion, and nobody seems to really want to own that. I guess I'd like to know, does Medica then object to having this language, other than the fact that they now think that for-profits should also have to act like nonprofits?
And you can bring some more clarity, and please reintroduce yourself again, because I didn't get your last name.
Absolutely, Madam Chair. My name is Jay McLaren. I'm with Medica. Thank you. So there was a question asked in another committee, and I'll answer that as well, which goes to the heart of what Representative Liebling is saying, is that my plan did not request and had no knowledge of the repeal that was in that law in 2017. I didn't even see the repealer and understand even what it did until the bill reached conference committee. So I just want to make sure to clarify that. That was clarified in the Commerce Committee. I want to make sure to clarify that in this committee as well.
So it just appeared in the dead of the night somewhere.
We had nothing to do, Madam Chair and members, when we had no knowledge of that language.
And so, Madam Chair, do they object to having this put back?
Mr. McLaren.
So as Ms. Commit talked about earlier, and she made it very clear, the Council of Health Plans, including Medica, supports and is fine with the original bill as came before the committee, before the amendments were added. And with the amendments, Catherine Commit has already discussed with the committee how that changed the bill fundamentally and how it changes the playing field in Minnesota, at least in the short term, if not the long term as well.
Got it. Thank you.
All right. Well, Madam Chair, if I could then maybe wrap up. I don't know if there are other members have other
Representative Albright.
questions. I'll save my comment to that until the end then, Madam Chair.
Representative Albright.
Thank you, Madam Chair. I shared with the committee members a document that I think maybe brings some clarity, if not maybe a little more balance to some of the assertions that I've heard from some of the testifiers with regard to HMOs. Used to be, and I think it's still true, that a person is innocent until proven guilty, but the assertion that just because you brought an assertion against an entity that there's a presumption of guilt, I think is maligned and is maligning of the entity. So I'll leave that for members to consider, but I think there are benefits to for-profits. I will end with this, and I think I will use this, as my colleague Representative Pinto said. I think there, prior to the amendment, I think there are, and with the adoption of the amendment, I think there are some negative externalities that occur because of that. And one of the things that I look at is, you know, the holding company structure under either a 501 or another chapter code, and I'm not going to go into that. But I think we've already heard in commerce, and it's troubling for me from the perspective of if you want to go down the road of making everyone a nonprofit, when you have nonprofits that have for-profit entities, I think you better consider the taxable situation that you put those holding companies in as they unwind those for-profits. I think that's a point of clarity that Chair Marquardt might want to review as well with you. But I will say that one of the things that I don't think nonprofits or for-profits have a monopoly on, and that's innovation. Just because you're a nonprofit doesn't mean that you own the market for innovation in terms of healthcare delivery or healthcare development. And I think competition is a worthwhile thing. You talk about mission in your opening statements with regard to they have a consumer driven mission or a mission statement that drives their operation. I would dare say the same thing of for-profits. Every entity has a mission. And whether that, you know, you want to decry the profit motive or not, competition drives innovation, which drives you to stay in the marketplace and deliver what the consumer is looking for. And sometimes, you know, because you couch yourself in a nonprofit, I'm not saying that you become comfortable, but I think competition does incent all parties to the table to innovate for the benefit of, to the point around this table, the ultimate focus of our debate here, and that's the patient and the individual citizen. So appreciate the conversation.
Representative New.
Thank you, Madam Chair. And I guess my question is for Ms. Kmitt. I actually wanted to revisit. It looked like you had an answer for the question on the net earnings language on page 3 in subdivision 8A. And I was hoping that actually you would clarify that. I mean, it sounds like, and frankly, I agree that section 8 was an important section to amend onto the bill, but it really does have some implications here, and I'm wondering if you could define that further for us.
Ms. Kmitt.
Madam Chair and Representative New, I think you're asking in response to Representative Fisher's questions. Yes, the answer is yes. Health plans follow generally accepted accounting principles.
Thank you.
Thank you. So I'm going to close with Representative Chair Liebling.
All right, thank you, Madam Chair. Well, this has been a really interesting discussion, and members, I think, of course, the last section there was not, you know, that was put on in another committee by members who, you know, wanted to make sure that going back to nonprofits only wouldn't hurt costs and so on. And I wish that same concern had been put forward before this new change was done. But focusing on the 8A, which honestly is kind of, for me, the heart of the matter, subdivision 8A, it's very interesting to me that, you know, Mr. McLaren talked about how Medica has, you know, we were a nonprofit holding company and none of this money goes to shareholders and all of that. And yet, they're afraid to have, or I should take that back, they're not afraid, but they don't want to be held to this standard unless for-profit companies are also held to that standard. So what are they telling us? They don't want to behave like nonprofits. If you're, why are you, this says that you use your money for the nonprofit purposes of the health maintenance organization in providing comprehensive health care. That is the heart of the matter. And if having nonprofits do that is somehow giving them a disadvantage with for-profits, then, I just don't know where we are. I mean, it seems to me that that is the heart of a matter. If you are a nonprofit and you are getting the advantages in the marketplace of competing against for-profits as a nonprofit, where there are tax advantages to that are given to you by the people of Minnesota, and yet you're saying we can't compete with the for-profits if we have to use our net earnings for the nonprofit purposes, then what is the difference? I don't know why we allow anyone to have nonprofit status in that case. Perhaps we should tax them all the same and let them all. I see Representative Schumacher likes that idea. But, this seems to me this is pretty core. If we're going to give them, we're going to give them the benefits of being a nonprofit, which means that they are a mission-driven organization. Now, I'm not saying that there's anything wrong with for-profits, Representative Albright, but they are, and yes, they have missions, but their mission is also to make profit, which is not an evil thing, but they are driven by a different set of considerations. They need to satisfy their shareholders, usually. They need to, if they're sold on a public exchange, they need to worry about their share price, those kinds of things. And our nonprofits don't have those considerations. It's a different set of considerations. And yet they don't want to be held to the standard of a nonprofit. They want the for-profit. I don't know how before this was amended to say nonprofit in here, I don't know how, I'd love it if I could hold for-profits to this same standard, but it's not in the nature of a for-profit.
Chair Liebling.
So I will wrap up, Madam Chair. So I ask members to support this.
I do think they support subdivision 8A. It is the section 8 that makes it unfair. I think that's what I heard. But we're going to go to a vote. We're going to work on it. We're going to go to a vote. And so Chair Liebling moves, let me see. There be no further discussion. Chair Liebling renews her motion that House File 1378 as amended be recommended for re-referral to the Committee on Ways and Means. All in favor say aye.
Aye.
All opposed? The motion prevails and House File 1378 as amended is recommended for re-referral to the Committee on Ways and Means. Thank you so much. So, Representative Schultz, we're going to go to 533. And this is an informational only hearing because the jacket is not in our possession. Okay. To Representative Schultz.
Thank you, Madam Chair and members. And as the chair just mentioned, that this bill was heard in the Commerce Committee Wednesday early afternoon, but the revisor's been so busy they weren't able to engross it to get through the floor session on Thursday. So we should treat this like we do have the bill. I would like to hear feedback, and we're going to take testimony and take your questions, and then hopefully keep the language moving forward. So this bill addresses an issue that was created as we just discussed in Chair Liebling's last bill, when we allowed for-profits to start operating here and potentially having nonprofit HMOs convert to for-profit without any guideline. So this has been drafted by the Attorney General's office with input from the Department of Commerce and DHS and others. So we're going to hear some testimony from the AG's office. They're going to walk through and explain the bill, House File 533, as an informational only presentation.
Madam Chair, members of the committee, my name is Benjamin Velzen. I'm an Assistant Attorney General with the Minnesota Attorney General's Office. I manage the Charities Division in the office. I'm testifying, of course, on behalf of the Attorney General's Office. Attorney General Keith Ellison is committed to protecting the public's interest and supports this bill as a way to better protect Minnesota taxpayers when charitable assets being held for their benefit are transferred from HMOs to for-profit companies. So before I get into the substance of the bill, just a little bit of background and why it's so important that these provisions are enacted into law. As we heard a moment ago, from 1973 until 2007, HMOs in Minnesota have always been nonprofits. They've received substantial benefits of being nonprofits over these 4 decades, which are effectively subsidies from Minnesota taxpayers. They have received, of course, various tax exemptions over the years and have received substantial revenue for managing and administering the state's health care programs. From 2002 to 2012, HMOs received $21 billion in Minnesota taxpayer money as revenue to administer the state's managed care contracts. These managed care contracts were worth $5 billion in 2015 alone. Major Minnesota nonprofit HMOs currently hold about $6.4 billion in charitable assets, $2.9 billion of which are reserves, and that's of the end of 2017. Given all these benefits conferred on them by Minnesota taxpayers, HMOs have necessarily reaffirmed their public, not private purpose. This brings us to a conversion. What is a conversion? It's basically a jargon for the switch of status from a nonprofit to a for-profit. It can take several forms, but the most common form of converting from a nonprofit to a for-profit is a simple asset transfer. And the most common form of asset transfer is a for-profit simply buying an HMO, a nonprofit HMO's assets. The question then is, when a conversion occurs, what happens to all those charitable assets that the HMO has been holding? Do they go back to the benefit of the Minnesota taxpayers who have subsidized their operations for 4 decades, or do they go to pad the bottom line of the for-profit company that is acquiring them? Well, Attorney General Ellison believes HMO's charitable assets should be preserved for the benefit of Minnesotans. Unfortunately, as we have learned from the experience of other states, this does not always happen. I'll give you a few quick examples. In Ohio, the management of the nonprofit Blue Cross of Ohio accepted an offer to sell the nonprofit health plan to a for-profit company. The sale did not provide that the Ohio public would receive anything from the benefit, any benefit from this conversion. Instead, various Blue Cross executives were scheduled to receive $25 million in payouts, personally enriching themselves as a result of this conversion. Something similar happened in Indiana. In Indiana, preceding the public stock offering of the nonprofit Indiana Blue Cross, its executives purchased 985,000 shares of stock in the successor for-profit company. The executives paid about $261,000 for these shares. Soon after the initial stock offering, the value of the HMO's executive stock holdings went up by about 10,000% to $29 million. Again, something similar happened in Georgia. There, the nonprofit Blue Cross of Georgia converted to a for-profit corporation, and the Georgia public received nothing. Shortly after converting, Blue Cross of Georgia sold itself to a for-profit insurer, and the company's executives and employees received $28 million in bonuses. And these are not isolated incidences. Conversion problems regarding executives getting golden parachutes or the public getting shortchanged have occurred in at least 15 other states over the years. By contrast, if there's an appropriate law in place to review and regulate conversions, there can be substantial benefits to the state at issue. California is just one example I'll note. California has an appropriately robust conversion regulation law in place, and there, when HMO converted, it resulted in $3 billion being used to capitalize a new California foundation that benefits the public health of Californians. So this brings us to House File 533. I think there's a packet summarizing the provisions. I'm happy to specifically discuss or answer questions from members about any of those provisions, but I want to just give a broad overview of a couple of key things the bill does and does not do. So broadly speaking, the bill subjects large asset transfers from nonprofit HMOs to for-profit companies to Attorney General review, and that's to ensure these asset transfers are in the public interest. It also subjects asset transfers of nonprofit assets out of state, that is a Minnesota HMO shipping Minnesota charitable assets to another state to prior AG review. Importantly, HF 533 is not retroactive. It will not apply to any conduct that occurs before its effective date. A couple other things to note about the bill.
Yep.
First, Section 4 of the bill is the main section of the bill imposing this AG review of conversions to ensure they're in the public interest. This only applies to certain types of asset transfers. So, for example, it does not apply to Minnesota nonprofit asset transfers. As I just mentioned, it only applies to nonprofit to for-profit asset transfers or out-of-state asset transfers. Second, Section 4 of the bill does not prohibit anything at all. All it does is require AG review of these significant asset transfers to ensure they're in the public interest. Lastly, Section 4 does not apply to the day-to-day operations of HMOs. Section 4, again, only applies to these certain specific types of large asset transfers, i.e. asset transfers to for-profit companies or asset transfers out of state. And I certainly hope that Minnesota HMOs aren't doing that every day. And I think if they are, that's a different conversation to have. And then one final thing to note before I'm happy to take any questions is there's been some discussion of this level playing field. You know, how do these bills interact between nonprofit and for-profit HMOs? And I would submit to members that nonprofits receive substantial benefits as a result of nonprofits. And if you had for-profit HMO representatives here today, they would testify that those benefits put them at a disadvantage to nonprofits. I mean, the federal corporate tax rate is 21%. Nonprofit HMOs don't pay that. I mean, that's just one example of the numerous benefits that nonprofit HMOs have received over the last 4 decades and continue to receive. So I think on balance, you know, I was scratching my head a little bit when I heard that earlier testimony on the level playing field issue. So with that, like I said, I'm happy to answer any questions, especially if there's particulars about what's in the bill or the implications. Thank you.
Thank you for being here and breaking down the bill for us. Appreciate it. We're going to move to our first testifier, Sarah Greenfield. Welcome back. Ms. Greenfield, please introduce yourself for the record and who you are and proceed.
Hello, Madam Chair, members of the committee. My name is Sarah Greenfield. I apologize, I forgot to give this in advance, just a visual to hand out. Again, I represent Take Action Minnesota. And as I said, Take Action opposed and still opposes allowing for-profit HMOs to operate in our state. However, if they are to be permitted, we should learn from the experience of other states, many of whom didn't pass their conversion regulations until many public benefit assets had been lost or nearly lost. In California, that $3 billion transfer of assets to the foundations that was mentioned came about after Blue Cross of California initially offered to donate only $100 million to charity. Blue Cross had argued that their transferring of 90% of their assets to the for-profit WellPoint was only restructuring. But strong conversion regulations ensured that all of their assets did remain in the public benefit. And those regulations had been passed themselves in response to a series of conversions in which the public benefit assets were undervalued. And you have a chart now being passed around that shows some of those. Because of, in Maryland, when WellPoint tried to buy Care First, because of conversion language that had just been passed, their insurance commissioner was able to review the purchase and hold public hearings around the state, uncovering, among other things, that $75 million was to go to Care First executives. That conversion was found not to be in the public interest and was denied. In Ohio, a controversial conversion proposal from one nonprofit inspired conversion legislation that was employed in a subsequent merger between a nonprofit and Anthem. But the review of the merger was not open to the public. Only $28 million in assets were protected, and the board of the new foundation included the for-profit insurer. So a lot is at stake in getting this right. These examples point to the importance of 3 things, all of which this bill does well. The Attorney General has the opportunity to review conversions, gather independent assessment of value, and protect public assets in the public interest. The public has the opportunity to have input into these decisions. And equally important, the governance of the resulting conversion benefit entity is independent and responsive to community needs. So we ask you to support House File 533.
Thank you so much.
Thank you.
Okay, Catherine Commit. Please, again, welcome back. Reintroduce yourself.
Thank you, Madam Chair and members of the committee. Catherine Commit from the Minnesota Council of Health Plans. Thanks for the opportunity to testify. Let me be abundantly clear. Minnesota's nonprofit health plans are not afraid of more competition. But we are very concerned that this bill will give a clear advantage to for-profit HMOs over the local nonprofit HMOs. You couldn't be an HMO in Minnesota. When the law was enacted in 1973, it was specifically required that they be nonprofit because the legislature was worried about this new entity, these new things called HMOs, and what they would do. So they insisted that they be nonprofit. And that is the world we all operated under. You can see that United Healthcare didn't come in to become a nonprofit HMO, but with the change of the law in 2017 that we did not ask for, we now have a situation where we have for-profits entering the market. And what we're asking for is for there to be a level playing field, for the rules to be the same. Regarding the HMO conversions to for-profits, this bill imposes very broad and sweeping regulatory authority by the AG to review and restrict any effort to convert. I'll say it slowly here. Minnesota's nonprofit health plans are not interested in converting to become for-profit entities. It is not who they are, and it is not who they want to be, period. Like the amended language in Representative Liebling's bill, House File 1378, we have significant concerns about the language regarding asset transfers. The bill imposes multiple prohibitions on nonprofit HMOs that would not apply to for-profit HMOs. Nonprofit HMOs would be severely limited as to how they use net earnings, while for-profit HMOs would not. This is a huge competitive disadvantage for the nonprofit HMOs. The committee faces an important decision. What is the best public policy direction this state should take when it comes to HMOs in Minnesota? Do you want a market that is served by local nonprofit HMOs that are member-led and whose mission is to provide a community benefit? Or do you want more for-profit HMOs based in other states whose sole mission is to maximize shareholders' return on investment through dividends and stock options? I urge the committee to carefully consider the implications of this bill and the risk of creating far-reaching unintended consequences. We will continue to the language addressing conversions and for-profits to for-profits and asset transfers needs more work, and we will continue to work with the AG's office to see if we can find a workable solution. But for all of the above reasons, we respectfully oppose this bill. Thank you.
Thank you. Representative Schultz.
Thank you, Madam Chair. I just have a question for Mrs. Commit. So nonprofits, you've clearly stated they do not want to convert to for-profits. Would they reject an offer from a for-profit health insurance company if that company wanted to purchase one of the nonprofit health plans in Minnesota?
Ms. Commit.
Well, Madam Chair and Representative, that's a hypothetical question. Again, I will say they do not want to convert to for-profits. I don't know how to answer that question. I've never had a conversation with any of our health plans about doing that. They fundamentally believe in their mission as nonprofit HMOs. They want to serve the community. I think that people think that the nonprofit HMOs are so terrible here, but I assure you they do a terrific job, and if the for-profits do come in, we just better be sure we have a level playing field. Otherwise, it will mean the demise of the nonprofit HMO world.
Is there any other, anyone else in the audience who would like to testify on House File 533? Representative Schumacher.
Thank you, Madam Chair. I have two questions, one for Ms. Commit and one for the Attorney General's office. I will start with the Attorney General since he's right there. Really, I know that now if an HMO wants to make a significant transfer or merger or something that goes to you, I'm just wondering why it's the Attorney General's office and why it has been the Attorney General's office versus like Commerce or something like that.
Okay, Mr. Velzin.
Madam Chair, Representative, this bill is fundamentally about protecting the billions in charitable assets that Minnesota HMOs hold, and dating back actually to common law, the Attorney General has always been the protector and the preserver of charitable assets in every state where there is Attorney General. So the reason the bill is Attorney General focused is because that's we protect, are the primary protector of charitable assets in Minnesota.
Representative Schumacher.
Okay, that cleared that up for me. Thank you. To Ms. Commit, I know when we talk about nonprofit and for-profit, that the big advantage, of course, is the tax portion, but nonprofits still pay like payroll tax and that sort of thing, right?
Ms. Commit.
Madam Chair and Representative Schumacher, yes, that's correct. I think what's important for people to understand is that the health plan members who are members of the nonprofit health plan are the ones who really benefit because they're not paying additional taxes or paying higher premiums because the for-profit entity is focused on maximizing shareholder value and return on investment.
Thank you, Madam Chair.
Thank you. I have a question, just for clarity around this. So in 2017, we opened up nonprofits become profitable, or did we? And has it always been that for-profit entities were a part of the system? Whoever.
Madam Chair, I'll start and Ms. Commit can add anything, of course, that she would like. From 1973 to January 2017, the only permissible form of business regarding HMOs in Minnesota was to operate as a nonprofit. In January 2017, the law was altered to permit for the first time for-profit HMOs to become licensed in Minnesota.
So my question is that what I think I'm hearing, what we believe is that we need to operate as, HMOs need to operate as nonprofits. So are we trying to remove for-profits HMOs? Because that is what happened in 2017. We invited them in somehow. And so are we trying to remove for-profits from being HMOs?
Madam Chair, HF 533 does not roll back the 2017 law. I believe Representative Liebling's earlier bill, 1378, would. This bill would simply require, if the nonprofit was to convert to a for-profit, prior AG review to ensure that that conversion is in the public interest and the charitable assets of the converting HMO are fully protected.
So my last question is, because what I've been hearing is that nonprofits HMO do not want to be a for-profit HMOs. You like the benefits and the status of where you are. Okay. That's my clarity. Okay.
Madam Chair, if I could just make a comment. Yes, you're correct. The current nonprofit HMO industry wants to remain nonprofit. However, the amendment that Representative Liebling put onto her bill and the language that's in here creates a disadvantage. We just want to make sure that the rules are the same. We're in a different landscape now where we've got for-profits, and if they don't have to play by the same rules, it won't be fair.
It's clear to me. Okay, thank you. Mr. Velzin.
Yeah. Madam Chair, again, to that level playing field issue, Section 4 of the bill, which it's my understanding the Council has concerns with, only applies in two situations. Significant transfers of charitable assets to a for-profit company and significant transfers of charitable assets out of state. Absent HMOs doing one of those two types of transactions, Section 4 of the bill does not interfere with their day-to-day operations or impose any additional obligations on them. Like I said before, I certainly hope that our HMOs aren't transferring routinely large amounts of charitable assets to for-profits or out of state.
Thank you. Representative New.
Thank you, Madam Chair. And I apologize that I forget your name to the testifier. You've said a couple of times now that you hope that this isn't happening. Is this currently being tracked? Has it happened? Is it happening ever? I'm wondering what information you have currently.
Madam Chair, Representative, there have been significant asset transfers by a particular HMO over the last 2 years that are public and were discussed in a prior committee hearing. I believe of $30 million, $55 million, and $90 million over the last 2 years. So we know about those, but as often says, we also don't know what we don't know. So it's possible, I certainly hope not, that there are other significant asset transfers that haven't come to light.
Madam Chair.
Representative New.
Thank you, Madam Chair. And with those transfers, am I understanding correctly that this does not necessarily prevent the transfers? It monitors. So were those transfers found to be acceptable? Did you have concerns with those transfers?
Mr. Van Zin.
Velzen. Madam Chair, Representative. The Attorney General's office did not find out about any of those transfers, well, 2 of them until after the fact, and they were already accomplished. And one at a very late stage in the game, and we expressed concern over it, and the transfer went forward anyway. So this law would give us the tools. Well, the HMOs would have to provide notice prior to nonprofit to for-profit asset transfers or out-of-state asset transfers, and give us the tools to review those proposed asset transfers to ensure they protect and preserve charitable assets and are in the Minnesota public interest, rather than us finding out after the fact when the asset transfer has already occurred and it's a lot harder to do anything.
Thank you, Madam Chair. So under current law, do you have the ability currently to review? And I mean, you said it may be harder. I assume you have to go retroactively, review what has happened. But does the Attorney General's office currently have the ability to do that and take action on that?
Mr. Velzen.
Madam Chair, Representative, there are current statutes in place that, in general, there's very general statutes to allow us to attempt to protect charitable assets. What I can tell you is that 2 different Minnesota nonprofit HMOs have, at different points in time, one to me personally, their lawyers have said, we would fight application of those laws to us in a court if it ever came to it. So what this bill does is put in place a prior, like I said, notice provision that says you can't engage in these asset transfers without prior sign-off from the Attorney General's office that protects charitable assets, that those asset transfers are in the public interest.
Okay, Representative New.
Thank you, Madam Chair. So it sounds like you do currently have some authority here. You are looking to strengthen the authority of the Attorney General's office on this matter. You are looking for the authority to be the final stamp of yes or no on whether or not this can move forward, whereas right now you do have recourse if you do find something to be questionable.
Mr. Velzen.
Madam Chair, Representative, I would say that that's speculation right now because there's never been a court ruling on this. And as I mentioned, the HMOs have indicated that they would challenge our authority to assert that they have improperly used their charitable assets. And the same general laws that protect charitable assets are on the books, I think, in most, if not all, states. And as I mentioned before, that has not stopped conversion, golden parachutes, and shortchanging the public and, calamity after calamity in other states. So I would not be sitting here testifying in favor of this bill today if I thought that the Attorney General's office currently had the tools to appropriately address this issue.
Mr. Velzen, it seems like to me, because of the change in law in 2017, that it opened up a door that created this possibility for nonprofits to do what they've done. And had this law not been changed in 2017, where we brought for-profit entities into the HMO market, we wouldn't be sitting here having this bill here. Is that your understanding?
Madam Chair, correct. If the law had not been changed in 2017, Minnesota HMOs would continue to be required to be nonprofits.
Representative New, Harvey.
Thank you, Madam Chair. And actually, your question spurred a good question. So what you're saying then is that these transfers of concern are specifically from these HMOs, these nonprofit HMOs, to for-profit HMOs? Because that's what changed in 2017.
Mr. Velzen.
Madam Chair, Representative, of the 3 asset transfers I mentioned earlier, 1 was an out-of-state asset transfer, 1 was to a for-profit affiliate, and 1 of the asset transfers actually occurred about, 6 weeks ago. It concluded at the end of January, and after speaking with representatives of the HMO, it was a nonprofit to nonprofit, but they indicated they weren't sure whether there was going to be a further transfer of the assets through additional affiliates. So the end recipient of the most recent asset transfer is yet to be determined.
May I respond to
Take a
that?
moment and let Representative Loeffler and come back. Representative Loeffler.
Well, thank you, Madam Chair. And I think this is an important discussion because I think the taxpayers want us to make distinctions between for-profit and nonprofit. And that's probably more important to them than, quote, the level playing field. I don't want to have our nonprofits all become for-profit clones. This is a multi-billion-dollar business in our state. Just think of how much of our budget goes into medical assistance in MinnesotaCare. It's billions of dollars, and think of what that would mean in income tax receipts if they were paying income taxes as for-profits. And it's a compact between these organizations and the people of Minnesota who are saying, we want a service system that's focused on the people and their needs, not on profits. And they want us to safeguard that. These companies have for years had tremendous benefits financially by not having to pay sales tax, income tax, property taxes, all kinds of taxes that would have been, we would have welcomed those into our pockets as we were doing budgets, but we have a concern that that might reduce the quality of care, the focus on care that we have built up in our healthcare system. The whole health maintenance model was supposed to be focused on keeping people healthy, preventing disease whenever possible. It was an alternative to a fee-for-service model where you made the most money when the sickest people came to you, and instead said you want to have health care focused on the individual and good, positive health outcomes from the beginning to the end of life. And so I think that it's our job to make sure that that compact is still honored. And I think if it's honored well, I don't think our nonprofits have to worry. Because if they're doing a great job of serving people who are enrolled in their plans, they are demonstrating in many different ways their commitment to mission. If they can brag about outcomes that are better than others who take a chunk off the top to pay shareholders and then another chunk off the top to pay taxes, I think they've actually got the advantage in this, and they've got a head start. And I don't think they should be afraid as long as they're willing to continue to commit to the people of Minnesota that in exchange for being nonprofit, they're going to focus on that and not just always be looking over their shoulder and trying to be a wannabe. And I remember when we had, as IAG, Mike Hatch, and he went after our HMOs because they were acting too much like for-profits and putting a ton of money into, buying suites at athletic events and taking executives on trips, and I don't remember all the details, but he said, whoa, wait a minute. This isn't how a nonprofit acts. A nonprofit focuses on using its resources to invest in its services. And I think this continues that legacy, and I'm not worried that we will have a robust and successful nonprofit health maintenance marketplace if they continue to focus on the advantages that they have. And continue to be mission-based and outcome-based and not try and pretend that they're just like the other guy. They ought to be able to demonstrate that they're better because they don't have to worry about those excess costs.
Representative Albright.
Thank you, Madam Chair. So, Mr. Belzin, in the 3 transactions that you cite, can you identify an illegality to those transactions?
Mr. Velson.
Madam Chair, Representative Albright, I need to choose my words carefully because the full extent of the facts of those transactions are not known. We're currently attempting to ascertain the full extent of the facts of those transactions, and due to certain confidentiality provisions in Minnesota law, that's all I can say.
Representative Albright.
Thank you, Mr. Chair. So, Madam Chair, I'm sorry. So in the bill provisions specifies that it will review conversion transactions exceeding $10 million. So why not just put a transaction fee at $9,900,000?
Mr. Velson.
Madam Chair, Representative Albright, there is another provision, I think it's within the definition of conversion transaction, which you just cite, that says a series of separate transactions that in the aggregate reach that $10 million ceiling amount to a conversion transaction subject to AG review. So the bill does address that point.
Representative Albright.
Thank you, Madam Chair.
Okay, thank you.
And I will just remind the committee and the members as to what was said in the former question with regard to illegality. So, there isn't currently, and I appreciate Mr. Belzin's careful selection of words, there isn't currently any illegality found. So it seems to me like we're moving towards, rather than a legal standard, we're moving to a social standard. And I'll leave it at that.
Representative Robin.
Thank you, Madam Chair. To the testifier in subdivision 10 about the penalties and the remedies, it looks like the Attorney General has the authority to unwind these conversion transactions. So I just wondered if you could speak to that for a minute. Would that apply to the current one you're still investigating that's already happened? And so that's one question. The second question is, if the Attorney General earlier approved it, then he can still subsequently unwind it? And what would the basis for that unwinding be if it was something he had earlier approved in a future consideration of this? Because I think if for whatever reason they want to convert and then they can't rely that the approval is going to stick, I just wondered if you could address that issue. Thank you.
Mr. Velson.
Madam Chair, Representative, to your first question, certain types of conversion transactions, I believe it's subdivision 2 of section 4 perhaps, I could have my subdivisions wrong though, are prohibited, and mainly those are conversion transactions that are driven by the financial self-interest of HMO executives. So if an nonprofit HMO executive is going to get a bonus, a multi-million-dollar bonus, or get stock options in the new for-profit company to which the assets are being transferred, those type of things, those are prohibited. So that unwinding language is if it turns out later that a conversion transaction was entered into and there were some hidden bonuses paid to HMO executives, and this just as an example, the Attorney General's office could then unwind that unlawful conversion transaction. And this is similar to if two companies merge. I used to do antitrust, which is where this example is coming from, and it's that merger is a merger to monopoly. The Department of Justice or the Minnesota Attorney General's office or the Federal Trade Commission can sue to unwind that merger. It's the same kind of concept there. To your second question, if the Attorney General approves the conversion transaction, obviously it would not be in violation of this section because the unwinding authority is tied to a conversion transaction that is in violation of Section 4 of the bill. And so as part of the review and approval process, that it just wouldn't functionally follow that if the Attorney General approves a conversion, I would assume that we're not going to approve a conversion that's in violation of the law. So,
Representative New.
I'm fine.
All right, okay. So, there being no further discussion,
Do you want to respond?
Representative Schultz renews her motion.
It's just
Oh, there's no motion, this is
informational.
an informational hearing. All right, so, okay, so I want to thank everyone from this robust discussion on House File 533. And now we're going to move to House File 572. Representative Schultz, would you like to move the
Yes,
bill?
thank you, Madam Chair. I move that House File 572 be recommended for re-referral to the Committee on Ways and Means.
Thank you. We have the bill before the committee. Representative Schultz, please present your bill.
Thank you, Madam Chair. House File 572 creates medical loss ratio requirements in the state of Minnesota to ensure that Minnesota premium dollars are going to be used for medical care. And language has been drafted by the Department of Commerce. This bill was in the Commerce Committee on Wednesday this week being reviewed. And it's really vital to protect, as so many people in Minnesota are facing very high health insurance premiums. This is one area we can look at to help address that growth in health insurance premiums that are affecting a majority of people in the state.
All right, thank you, Representative Schultz. So we have no scheduled testifiers. Is there anyone? We have one? Okay, Mrs. Demitz. Please reintroduce yourself again for the record.
Madam Chair and members of the committee, I'm going to be super brief. Appreciate the effort that Representative Schultz is making on this bill. Catherine Commit from the Minnesota Council of Health Plans, I'm sorry. Unfortunately, it creates a different, the new MLR requirements in this bill are different from the federal standards. And so we would like to keep working with Representative Schultz to try to harmonize those so that we're not having to do two different or meet two different standards. And then I would also just encourage there be discussion with the Departments of Commerce and Health to weigh in on this because it looks like there would be some fiscal impact to it. And then lastly, this bill also has that same troubling language in it, Section 4 of the bill. And I'm not going to repeat it, but I am just calling it out again. So this language that creates this unleveled playing field is moving in about 3 or 4 bills. So we have serious concerns about that. Thank you, Madam Chair.
All right, thank you. Is there anyone else in the audience who wishes to testify on House File 572? Members have any questions? So there being no further discussion, Representative Schultz renews her motion that House File 572 be recommended for re-referral to the Committee on Ways and Means. All in favor say aye.
Aye.
All opposed? The motion prevails and House File 572 is recommended for re-referral to the Committee on Ways and Means. Thank you. Okay. Okay.
He had to go submit amendments for Monday.
Okay, we're waiting on Representative Albright. Is that the last bill of the day? Which is the last bill of the day to come back. So why don't we take a 5-minute break? Oh, here he is. Okay, Representative Albright, you are up. What's that bill number? 2371. So our next bill is House File 2371.
That's right.
All right.
Madam Chair, it's so good to see you from this
Yes,
perspective
yes.
today. Thank you so much.
Would you like to move
I'd
the
like
bill?
to move House File
2371.
2317 before the committee. Thank you.
71.
That one, too.
Okay. So Representative Albright would like to move House File 2371. We have the bill before the committee. Representative Albright, please present your bill.
Thank you, Madam Chair. In 2017, the substance use disorder reform was approved by this body with the goal of improving Minnesota's addiction treatment system. One primary goal of substance use disorder reform was to allow individuals with substance use concerns to directly access care by receiving a comprehensive assessment through a county or a provider of their choice. As the process of implementing substance use disorder reform has evolved, counties have identified significant workforce challenges related to current credentialing requirements that impact county employees. I have a testifier with me today, and I will defer to him to explain the bill, and I urge the committee's support.
All right, thank you. Please, welcome to the committee. Introduce yourself for the record, who you're with, and proceed with your testimony.
Thank you, Madam Chair. Thank you, Representative Albright and members of the committee. My name is Bob Rarrett. I'm an administrative manager for Hennepin County in their Health and Human Services Department. And I'm here today representing the Minnesota Association of County, the Minnesota Association of County Social Service Administrators, I apologize, or MACSA, which I'll use from this point forward. As Representative Albright mentioned, substance use disorder reform was passed in 2017 and was intended to improve statewide access to care. I'd also like the committee to know that MACSA has worked closely with DHS throughout the development and implementation of substance use disorder reform, and we appreciate their efforts. Over the past year, myself and other MACSA representatives met regularly with DHS leadership to work through challenges and opportunities related to this important legislation. I'd like to provide a brief overview of the issue we're discussing today. Under substance use disorder reform, professionals with an LADC or a licensed alcohol and drug counselor credential who work for a licensed treatment provider may bill Medicaid and complete comprehensive assessments under SUD reform. However, county assessors are required to possess an LADC supervisor credential as outlined by the Board of Behavioral Health and Therapy. This supervisor credential add-on requires county employees who are licensed alcohol and drug counselors to have an additional 12 hours of supervisory ethics coursework and 3 years experience working in a treatment environment. Under the Rule 25 process, that's the process that we're currently or historically have been operating under, county assessors are not required to have this level of credentialing. Therefore, this new requirement will exclude many county employees who now perform this service from doing so going forward. While MACSA agrees with and supports SUD reform, substance use disorder reform, this requirement for county employees to meet a higher credentialing standard affects our ability to provide a needed service at a critical time during an opioid epidemic. Rural counties are especially challenged to find any qualified staff who meet this credentialing requirement. And rural counties serve a more central function in assessing their residents and referring them to treatment options. The unintended result of this requirement may limit access rather than expand or improve access as intended. My colleagues from outside of the metro who unfortunately could not be here today are extremely concerned that the challenges that current professional credentialing requirements pose could limit their ability to recruit and retain a workforce. What we're asking is simple. We would like DHS to develop a process by which an alternative certification process or variance could be granted that assures high-quality assessments are being performed in line with the state's goal of increased access to the right treatment service at the right time at the right place. We appreciate the committee's support. I would stand for any questions. Thank you, Madam Chair.
Thank you so much for your testimony. Okay, is there any further testifiers on this, on House File 2371? Okay, members' question, Representative Freiberg.
I have a series of questions for the bill author.
Okay.
First, Representative Albright, what do you see as an acceptable alternative to staffing credentials such as the supervisor credential that your testifier mentioned?
Representative Albright.
Thank you, Representative Freiberg. And I appreciate the comments made by my testifier, and I stand by them.
Representative Freiberg.
Maybe the question should go to your testifier. What do you see as an alternative credential, an acceptable alternative credential?
Mr. Robert.
Thank you, Madam Chair, Representative. I think what counties recognize is that we have an existing workforce that already does this type of work, but who won't meet the new credentialing standards. Therefore, a current workforce that exists now within counties will not be, we won't be able to leverage them to do this new work because the credentialing standards exclude them from being considered in this matter. Thank you.
I guess I just have the one question.
Any Representative Bonner?
Thank you, Madam Chair, Representative Albright, and to the testifier. So I appreciate the idea here that certainly if we have good employees, we want to keep them. Makes sense, right? And certainly, especially in areas where we desperately need them. So appreciate that. So here's my question. If there are some folks who are not currently meeting those qualifications, what is your thought or plan on how to get those employees to the place where they might be able to qualify?
Mr. Roderick?
Thank you, Madam Chair. Rarit. Yes,
Rarit.
that's all right.
Rarit, okay.
Representative. The idea is, what we face right now is we've had a current workforce shortage for addiction professionals in the state. We've had that for some time now. What this additional credentialing requirement does is it further limits our ability to meet current expectations for treating individuals in need of addiction care. So our hope is that the workforce will adjust to the need eventually, and that over time, as you might have, as I stated here, there is a 3-year experience requirement in working in a treatment environment that's required under the supervisor credential. So counties are expecting at least 3 years before they can get qualified people who have that experience requirement met in many instances. And it's just an overall adjustment of the workforce to the new credentialing requirements, and depending on salary and the ability of the workforce to adjust to the need. It's hard to say how long that could still pose an ongoing sort of challenge for us. So I appreciate the fact that DHS is looking at the issue, but my colleagues believe that they haven't gone far enough in terms of ensuring that this existing need is met through the current workforce that we have, and through the recognition that it may take several years in order to build the workforce to meet this new requirement.
Okay. Representative Bonner?
Thank you. And I certainly don't want to keep asking questions because I know we're all anxious to get out of here. But that answer is a little bit vague, pardon me. But so I appreciate that obviously the requirement for the levels of years of experience is something that has to be earned. So naturally that will take time to acquire. But I'm trying to understand what other pieces of the current requirement are a challenge for you, and what might be a pathway to help employees get to that place where they are prepared, is I guess where I'm trying to understand.
Okay, Mr. Roderick.
Madam Chair, Representative. The biggest challenges are in rural counties where there are very few provider networks to serve the need, and counties serve a vital function there. But again, recruiting individuals to work in this profession who meet these standards in rural counties, based on what my colleagues are saying, is nearly impossible at this point. And part of that has to do with the salary, the rate of pay that they're able to provide to these employees. So it's not just a matter of meeting the credentialing requirements, it's recruiting to these rural locations using incentives that draw people into this profession and to those locations where they're needed.
Representative Bonner.
Thank you, Madam Chair. Representative Albright. Mr. I'm sorry, I'm still not quite getting the answer that I'm looking for. So I appreciate, again, we need them. Totally get it. I appreciate that we need to recruit them and retain them. 100% with you. I even agree that we probably need to look at them getting up to snuff on experiential credentialing, you know, that piece of the qualifications. But what I haven't heard from you is I've heard these vague references to how they don't meet the qualifications, but I haven't heard any concrete examples of how they might not meet the qualifications and examples of how we might get them to the place where they would qualify. So that's what I'm trying to understand, because if it's something as simple as they just don't have as many years of experience, we all know what the remedy is for that, right? We get it. But I guess I don't understand the level of the qualifications that are not being met, or do you know what I'm saying? So if you're a nursing assistant, for example, there's specific duties or functions of your job that you need to understand in order to perform it well. And while experience certainly makes a big difference, there are certain mileposts, right, that you need to have to do that job. And I guess if we're going to say that they don't meet all the mileposts, I'm trying to understand what might some of those mileposts be that are a particular challenge for our rural communities, and what might be a remedy to get them there, so that they do qualify. Because again, if they're good employees, we don't want to lose them. I agree. But I'm still not understanding from you what those items are that are the challenge. We just have sort of this vague, well, they just tell us it's too difficult. So what does that mean?
So what I would like to do, Representative Bonner, is maybe you outline, because he's tried to answer it twice. Case managers. You know, and maybe you guys can sit down and maybe you can make it a little bit clearer, if you can, around what's the barriers right now. I do believe we want, and we're trying to like really need a workforce, especially in rural Minnesota, and to make sure that we have alcohol and drug counselors, especially now with the whole opiate epidemic.
Oh, yeah.
Right? So we don't want to make sure that we're creating, putting barriers or putting, maybe barriers in a way that we're losing counselors right now at this moment, especially in rural Minnesota, where they're needed and there may be a shortfall. So my hope is that Representative Albright and Mr. Rederick can continue working on some differences that you may have in some of the fears that may happen because of this bill. Representative Albright?
Madam Chair, brevity is my best friend right now.
Thank you. Thank you.
So I'll renew my motion.
Thank you. So Representative Albright renews his motion that House File 2371 be recommended for re-referral to the Committee on Ways and Means. All in favor say aye.
Aye.
All opposed? The motion
No.
The motion prevails, and House File 2371 is recommended for re-referral to the Committee on Ways and Means.
Madam Chair.
That is Representative Newt.
Thank you, Madam Chair. I was hoping for just a moment, Representative Pinto had given me sort of a nod earlier, and I was hoping to just ask him if he would also commit actually to holding a hearing on the CCAP issue and the fraud that we're aware of, and to request Ms. Ham to come before the committee so that we can have an opportunity, or in your committee where it may be more appropriate, to hold that informational hearing and be able to dig into that a little bit further.
Representative Pinto?
Thank you, Madam Chair. And Representative New, thank you. Let me think. The Early Childhood Finance and Policy Division will be hearing a number of proposals relating to CCAP program integrity. Let me think. Regarding the particular individual, having that particular individual, I guess my thinking is that, as I said before, we have a second OLA report that's being prepared right now, And so my thinking, at the moment anyway, is to focus on getting that information, because the OLA is really in the best position to gather that. Let's see what is said on that. But I can assure you, and I've assured members as well, that we absolutely going to be hearing a number of proposals relate to CCAP program integrity in response to the thorough work that's been done so far, but then the even more thorough work that we're about to get. So thank you, though.
And then Representative Pearson.
I guess I kind of along that same vein. I feel like if we don't work on this now, I think we're losing on. We'd have a lost opportunity potentially. I think one of the issues that's come up is the access and availability of information, and actually that I think is in and of itself an important issue of this. And if we wait until after the OLA's second report, then we will not get the information that the OLA is looking for. And so it's something I would actually encourage to occur sooner than later. Thank you, Madam Chair, for the latitude.
Thank you for that comment. So members, I just want to say to you, to everyone, I just want to thank you all. We have met our first deadline. You have withstood and participated in an abundance of bills moving through this body. So I just want to say how much I appreciate all of you in the robust discussion. We have more to come. This is not the end, but I just wanted to just say that as we end the first deadline. Our next meeting is next Tuesday, same place, same time. Thank you all so much. Have a great weekend. We are adjourned.
This time?
We're adjourned.